now move to our second panel regarding community engagement. We've now heard from experts on the progress and the challenges around the behavioral health workforce. So now we want to talk about current programs and pilot programs that are in progress around the state, the various ways that they can contribute to addressing the mental health crisis. These next panelists have a strong commitment to healthcare justice and can speak more about how collaborating and peer-to-peer support can be transformational in serving communities. So we have three speakers: Brett Feldman, director and co-founder of USC Street Medicine; Dave Jalot, the co-chair of the Firefighter Behavioral Health Task Force, CPF, California Professional Firefighters 7th District Vice President, and President of the of LA County Firefighters Local 1014. I'm sorry if I mispronounced your name. Got it, good. I'm sensitive since my name gets mispronounced all the time. And finally, Dr. Vival Banvadia. Did I pronounce that correctly? Banvadia?
Yeah, that's perfect.
Okay, great. Got it. Second time. A physician with Advantage Healthcare Services. So why don't we go in that order that I listed you? We'll start with Brett Feldman.
Great. Hi, my name is Brett Feldman, and thank you, Senator Wiener and the committee for allowing me to come and talk to you today about what's going well in the world of behavioral health care and care for our neighbors experiencing unsheltered homelessness. And what's going well is street medicine, which is defined as the direct delivery of health care to people who are unsheltered, which is 75% of our homeless population, in their lived environment. I've been practicing street medicine since 2007 and now serve as the director for street medicine at USC. We provide about 10,000 office visits a year, except our offices are under the bridges. We also host the California Street Medicine Collaborative, which is our statewide organization. We have about 130 organizational members and have a pretty extensive workforce development and education arm, which trains and equips others across the state and really across the country to do this work. But the reason why I'm here today and the reason why street medicine needs to exist is because people experiencing unsheltered homelessness can't access healthcare the way the rest of us do. And so you start with extreme poverty plus social isolation. Then you add severe and untreated physical disability, substance use disorders, and mental illness. And then you top it off with a healthcare system that was never designed to serve them in the first place. In California, we've done a great job of making sure folks are insured. Between 60 and 80% of the people were insured, but only 7% are actually able to access their PCP, and only 3% are actually able to be seen by behavioral health care. And so in response and recognition of their sacred humanity, we go to the people, first to deliver an understanding love, and then the same quality of care on the street that you'd expect in a brick and mortar clinic. Our teams are made up of doctors, PAs, nurse practitioners, nurses, social workers, and many others, but the backbone of the teams are our community health workers, the people with lived expertise in homelessness who act as our street guides and make sure that we don't lose anybody. But we also know that healthcare is more than an office visit, even if that office is literally on the street. So we dispense medications, draw labs, do ultrasound, EKGs, all in the patient's lived environment. And this approach is distinctly different from mobile medicine or RV medicine, where you park the RV, people leave their encampment, even if they're worried about everything being stolen, to go to the RV. Instead, we go to the people with pickup trucks and backpacks and deliver care in their environment where they feel most comfortable. And at USC, we've had very good results doing it this way. For example, we've shown we can decrease hospitalization by 70%. But as it relates directly to behavioral health, because that's the charge of this committee, there are three continuums where we serve as that keystone, that stabilizing piece within the continuum. The first one is just access to behavioral health care, which you already heard a lot about. And so last year we published the California Street Medicine Landscape Analysis, which showed 70 to 80% of our programs are diagnosing and treating mental health conditions. We've had to train ourselves up to practice at the very top of our scope of practice as primary care. And the reason is because in that same report, if you add up the total number of street psychiatrists in the state, you get 5 FTEs. But we've actually had good results in doing it this way. For example, we prefer to use long-acting injectable antipsychotics. I give 1 injection, it lasts for a month, it's never lost or stolen or traded or degraded by the elements. It's just in there. And so using that treatment, for example, I remember giving Bullet his first injection behind Carl's Jr. for his schizophrenia. And in a few months, I look forward to watching him graduate as a drug and alcohol counselor to go back to the community to serve. I remember giving Jose his first injection also for schizophrenia outside of his broken down Corolla, where he lived with his family and 2 little girls. And after treatment, he was able to organize himself enough to complete housing paperwork, register his girls for school. And one of the happiest days was seeing little Amelia, who at the age of 9 went to school for the first time. I remember her leaving her Corolla, going to school, and she was so proud of herself, but I think even more proud of her daddy. The second area where we serve as that cornerstone is in housing. Since 2018, at USC, we've housed between 30 and 40% of everybody we see. And the reason is because medicine is seen as an instrument of peace, where we can build these trusting relationships quickly, start treatment immediately, and then refer into housing. And while they're waiting 5 months, 6 months, a year for housing, we continue to follow them so that when housing does come through, number 1, we know where they are, we haven't lost them. And number 2, their physical health is improved, psychiatric conditions are improved, they're using less drugs, and housing is more likely to be successful. And then finally is our role in crisis prevention and post-crisis management. Crisis prevention because if they're being treated for psychosis with antipsychotics, if they're using less drugs, they're less likely to have a crisis. If they do have a crisis, when crisis comes, if they decide not to transport, we come on site and take over care. If they do take them to the hospital, we also go to the hospital and then follow them on the street to continue care to prevent the next crisis. And so right now we're at this really critical point in our history of street medicine where we're transitioning from this Robin Hood grassroots movement into mainstream healthcare. And we've gotten tremendous support from the administration, from a lot of you in the legislature, and from DHCS, to the point that we now have 57 programs across the state with another 20 in development in 34 different counties. So this is not just in the big cities. And so moving forward, as we're thinking about legislation, the goal would be to make it that anybody wanting to go to the street to deliver care is able to do so without bureaucratic barriers. Because there needs to be more of us to go to the people with love and solidarity.
Thank you very much.